Ashish, have you joined?
Jitendra, can I check
Yes, sir.
the screen?
Yes, yes. Why not?
Yeah.
We can. We are not live now. Ashish, we
Yeah.
are not live now.
I think he mentioned recording in progress. That's why I don't know.
Only recording must be there. I
Hello.
think. Yeah, we are not on the YouTube now right now.
No, sir.
Okay, okay. Sir, you can check now. At 6 o'clock we will be live.
So I am audible.
Oh, yes, sir. Yes, sir. You are audible. And can I just your screen is just blank. Maybe. This is Dr. Suhas.
Yeah,
Yes,
got it now.
Yeah, we are getting it here.
Okay. I'll minimize. Yeah.
Yes, sir.
Right. Got it.
Shall I share my one, sir?
Yeah, you can check, sir, once.
Check.
It is seen.
Yes, sir.
Yeah,
It is visible. You can check in the presentation mode. Full screen. Yes, sir. It is there. Everything okay.
Okay.
Perfect. So we have some time here. We have 10 minutes.
Good 10 minutes.
Yes, sir.
Everybody is so prompt.
Absolutely, sir. And how is going on, sir?
Me?
Mahapatra, sir? Yes, sir. You also.
Yeah.
Bhubaneswar and Kochi, Bangalore. All.
If you are Mohit, you are asking me, I work from 8 o'clock to maybe 8 o'clock. After this, I have one more meeting.
Thank you so
From
much, sir. We are
7 to 9, that's a book release.
okay.
Somebody has. So I attend a lot of social. Yesterday I had 5 functions. Today morning we had a nursing function. Then I went for another function. Then after this one, I'll go for a book release about 15 kilometers from Nakia. That's a city. Tomorrow I have 2 functions, 2 nursing college, because this is the tomorrow is International Nursing Day.
Okay.
So we have about 6 nursing college in Bhubaneswar. So 3 of them have called me different places. I'll go and attend there as the guest. So I attend more social function, book release, spiritual talk, health related topic with the senior citizens. Part of life. So,
but they must be getting a lot of experience through you, sir.
Yes, yes or no, I don't know. They ask a lot of questions. Next week, I have a talk on healthy senior citizen, healthy senior, how to lead a healthy life, or peaceful retirement. They're all same. How can lead a good life after retirement? You have to think after a long time.
Yeah.
Retirement means after 65 years now. So maybe after 10 years, 15 years.
Yes, sir.
So I talk to people above 70, usually above 70. They are more worried for their future.
But it is. Yes, sir. Please go ahead, sir.
No. Dr. Mahapatra, sir, you're in Bhubaneswar completely now, or you go?
Completely. I have left Delhi 7 years back.
Yeah.
I don't have any house at Delhi.
So you're.
I'm completely.
So
I operate.
With at.
We are analyzing. I had written to you, na?
Yes. Chal raha hai, sir.
Life. I have 7 chapters. I want 7 more chapters from you, Deepak, Donpani, and 6 different places, so that we can write Indian experience.
No, that focus article was pending, sir. That's why Dr. Jogi was there.
Actually, we are not highlighting for international readers.
Yeah.
Because we always follow others.
Yeah.
You know, I was reading the rating of the book on Craniosynostosis. You see also that. They have given 3 out of 5. That's how if you write a book, they don't like it. I saw 3 reviews. I just now I was going through. Nobody has put a review for my book on split cord. Have you seen?
No.
Split cord mark.
Split. I have a copy actually, sir. I have a
So
copy.
I sent 50 people in India.
I have copy, sir. I have a
So
copy.
nobody, you write a review. Nobody has written a review because
Right.
no, review means how you comment on the books and to recommend this for your resident to read. Even though we don't like resident to focus on a topic because
Yeah.
they have to have broad base rather than a focus topic. But if anybody is working on split cord, thesis on the split cord, or thesis on lipoma, why not? What is wrong writing a thesis on lipoma? If you have 50 cases, that's a big series. I have operated 55 cases here in the last 5 years.
Oh,
Okay.
So lipoma, split cord maybe more.
yeah.
Mm.
But you
Not
don't have
easy.
you don't have residents, no, sir? You do have.
We have now, last year we have one resident was finished MCS. He wrote 30 papers. He wrote, I am telling him, write a review. How many people residents he wrote 30 papers of 3.5 years or something. I made him to write on everything. I think you read a paper, pediatric neurosurgeon in a general neurosurgical unit, for which, Yogi was asking a transitional phase.
So he has finalized it, I think, sir.
I think he has finalized that for neurosurgical focus.
Yeah.
That's absolutely right, because transition is very long for a super specialist, right?
Yeah.
Because if you're a general neurosurgeon to jump to super specialist is not easy.
Yeah.
I don't operate adult for last 20 years or so.
Yeah.
Now I have restricted 2 years below.
Yeah. Oh.
So 2 years also they go to other people, most likely. Unless a difficult pediatric case. A person I was doing an interventricular meningioma 10 years ago. She has a tumor in the jugular foramen and small daughter meningioma sitting over the flap without any attachment to the mother one, which was interventricular, trigonal.
Okay.
So it's like a daughter and sister relationship.
Apparently, we also had some jugular yesterday. That was really fascinating. Good it was. And I think Professor Mittal sir has joined. Sir, good evening. Can you hear us? I'm not sure.
His name is not visible.
Is that
it is there. Sir, am I audible? No. Okay.
Hello.
Okay, sir.
Yes. You are
Dr.
audible.
Sir, good evening.
Oh, yes. Dr. Mittal, good evening.
Good evening. Good evening, sir.
How are you?
Fine.
Good evening, Dr. Mittal. Dr. Suhas here.
Good evening.
Good evening.
Can we start now?
Sir,
56.
we have we just 3 minutes. We'll wait.
Okay.
Because there's rapid inflow at that time, sir. So we don't want to miss that.
Dr. Ajay will be there, Jitendra?
Sir, yes, I'm contacting through like WhatsApp and other reasons. And both Dr. Sharma also.
Yeah.
Dr. Sharma also has not.
Dr. Ajay.
Hello. Sir.
Good morning, Dr. Ajay.
Ajay.
Good
morning.
Namaste, sir.
How are you?
Well, sir.
You are not coming to India?
I am, but not at the moment, sir. It's too hot. I'll come and after October.
December.
Yeah, December
January.
time.
It had gone up to 46 in Bhubaneswar.
Yes, it's too hot now. And the weather here is the best this time of the year, sir. May, June, July, August, September is very good weather. After October, it becomes miserable. I mean, today is such a nice day.
It's around 10, 15, 15. in your
No,
place.
it was 20 degrees today, sir. 22 degrees. It's nice and sunny. It's very rarely does it happen.
You can plan to come in February in Despian, Ajay.
I'll try because my son may decide to get married at that time, so there may
Oh.
be some
clash of events.
social issues coming up, which I have to keep in mind.
Huh?
You know, but I'll try. I cannot promise. Yeah, normally I love to come in February.
Yeah.
That is the usual time I come and see my mom. So that always fits in with my travels. But he is planning to get hitched. I don't know when, but you know,
He's
it
finished
is
his graduation?
very much time.
He's finished his graduation?
Yeah. He's a neurosurgery trainee in Queen Square.
Wow.
Ah, yeah, you told me. Yeah. But
Yeah,
that is finishing. He's finishing, or is it?
No, he's a junior. He's second year. He's just going to be second year this year. So
But he's
he
okay with
wants to
planning
do-
residency.
yeah, he wants to do PhD as well. So
Oh.
that will hold him back by another few years.
Yeah.
It's an 8-year training here. It's a very long training.
Yeah.
Plus, most people will do a fellowship and they will do a PhD. So they spend about 12 years in training.
Mm.
But the problem is, you know, it's such a long time they're in training. When they come out, they're finished products. They are up and running from day one.
Yeah.
They don't need much of hand holding.
Yeah.
They've done so much. It's like a job for them. They're in no rush to finish. It's a job.
Good evening,
They
sir.
continue
There.
as long as they feel like. Yeah.
Sir, good evening. I'm
Good evening, good
Nitin from Rishikesh. So in 1 minute we will start. We'll be starting, sir. Just a reminder.
Yes, I'm ready.
Yes.
Dr. Sharma has not come. Jitendra?
Sir, yes, sir. There is we are trying to contact him, but his phone apparently just 15 minutes back got into
Ramesh Sharma.
not reachable. Yeah, Dr. Professor R.K. Sharma from Panchkula.
Yeah.
So we will start, sir.
Yeah.
Hello, good evening, everyone, and welcome to the webinar series of Neurological Surgeon Society of India. Today, I welcome you all from India, Rishikesh, and from various parts of the country where we have today's speaker and senior panelists. And today's theme is Craniosynostosis and the craniofacial surgeries and the principles to manage complex craniosynostosis and role of ICP management while treating these patients surgically. And it is an interesting, very interesting pathology with a fascinating complex pathogenesis as well as equally fascinating surgical treatment, which includes endoscopic approaches also nowadays with complex frontorbital advancement or posterior vault distraction surgeries. So with this, let me move forward and introduce you to our guest speakers today, Professor Suhas Uday Kumaran, who is Professor of the Division of Pediatric Neurosurgery from Department of Neurosurgery at Amrita Institute, Kochi, Kerala, and Dr. Subhash Konar, who is Additional Professor Neurosurgery at NIMHANS, Bangalore. And I have with me very senior panelist, none other than Professor A.K. Mahapatra, who is currently Principal Advisor at Siksha Anusandhan and Vice Chancellor also at the same place, Bhubaneswar, India. And Professor R.K. Sharma is soon joining us, who is ex-HOD Plastic and Craniofacial Surgery at PGI and currently a senior consultant at Paras Hospital, Panchkula. And we have us who has joined Professor Ajay Kumar Sinha from Liverpool, who is currently consultant neurosurgeon at Alderhay Children's NHS Foundation Trust and Walton Center NHS Foundation Trust, Liverpool. So with permission of the senior panelist, honorable panelist, I invite our first speaker, Professor Suhas Uday Kumaran, on management of complex craniosynostosis. To you, sir.
Yeah, just sharing my screen.
You're on, actually. I'm just going to mute myself.
Yeah, I'm on screen, isn't it?
You are audible and screen is there.
Yeah. So good evening, everybody, and thank you, Dr. Jitendra. Thank you, NSSI, for giving me this opportunity to talk on something which is one of my passions, and it's my honor to talk in front of seniors and teachers, Dr. Mahapatra, Dr. Sinha, and Dr. Sharma, if he's already there online. So my topic, I'll try to I think complex craniofacial surgeries are very complex. Craniosynostosis is a very complex entity. Trying to simplify them to ask to the level of decision making is very important, and probably the crux of the situation. I'm going to do it the way which we handle it, trying to simplify how we decide in these conditions. So basically, most of us are very flummoxed by the issues which influence the outcome in these conditions. The geneticists, the neurologist, we as surgeons, on what determines the outcome. And of course, the key goal for all of us with different perspectives is to optimize the function. The complexity is all because there are multiple specialties involved, and there are multiple elements which contribute to the optimal function. So I'm going to simplify this as I started off with on how we decide, how we plan, and how we execute to optimize function. I'm going to give you probably gently a philosophical talk because something like ICP is going to be dealt by my colleague, Dr. Subhash, in my next talk. So we always start off with understanding parameters that are involved, the clinical features. We look at the radiology to see the sutural involvement. We look at the MRI to understand the presence of hydrocephalus and Chiari. And sometimes we do sleep studies when we see a presence of apnea secondary to obstruction. Is the airway involved? Are there aesthetic issues, and whether there are functional issues? Additionally, we look at, as I mentioned, MDCT, MRI, and the sleep study to understand what kind of a complex scenario we are dealing with. So when there are signs of raised ICP along with Chiari and hydrocephalus, along with the aesthetics, we usually start with posterior ventricular posterior wall distraction, posterior calvaриal wall distraction, or shunt in the youngest ones. If they are older and there's no involvement of hydrocephalus or Chiari, it boils down to frontoorbital advancement and remodeling. When airway is involved or aesthetics are involved, usually it's mid-phase distraction of some form. And then, of course, other functional issues are tackled over time. So these are not so compartmentalized, but at least this works well for us from youngest onwards. Additionally, we try to categorize these children into about five categories to create a strategy for management. For us, I'm just giving you a scheme of things, which the way which we think, but again, they are not so compartmentalized. They have to be tailored at each situation. So category 1 for us is non-syndromic single sutural and craniofacial cranio-frontal nasal dysplasias and hypertelorisms, where either you do a frontoorbital advancement surgeries or hypertelorism correction. So very straightforward. Mostly it's an aesthetic issue with some element of gentle element of ICP, which is not very evident, of course. Category 2 has ICP for us, and which may involve hydrocephalus or Chiari in the MRI, and we might have a sleep study which is abnormal. So here we use the posterior calvaриal wall distraction and frontoorbital advancement, plus with or without shunt, depending on the presence of hydrocephalus or depending on how much the hydrocephalus is controlled or how sick the child is. And the category 3 for us is where airway is involved, airway or ocular issues are involved, and there might be obstructive airway element. And here we would use mid-phase distraction of some form, along with frontoorbital advancement if aesthetics and frontal portion is involved. Category 4 for us is when ICP and airway both are involved, and with or without presence of hydrocephalus and Chiari. Here, again, posterior calvaриal wall distraction without this combination of surgeries. Category 5 is when we have a child with delayed presentation. Delayed is we would define as more than 5 years, when the child is probably essentially damaged in terms of cognitive issues, and then the element of contribution in terms of surgery is depending on the problem only. So this is just a broad classification which we do to decide on how to manage any child who comes with a craniofacial anomaly. Again, it's not very compartmentalized. It can be tailored. It is tailored when it's necessary. So as you see, the complexity increases as we go down, and the treatment workflow works towards my left to right, and the functional prognosis is from top down, because a child who comes delayed is extremely damaged. I'll get you through some scenarios which explain how we think. And in the category 1, as I said, is a purely aesthetic surgery. Of course, there's an element of raised ICP in a gentle way. So here, the standard, we would use some software to create some kind of a planning, which we refer to as the geometric correction. These are used by using multiple gentle softwares, like this is an Osirex, and this is a plagiocephaly, where we're trying to understand the discrepancy from the midline, which is the mandible. And we try to look at the discrepancy anterior, transverse, and from midline onwards. So this is the classical frontorbital advancement for these kids, standard plagiocephaly, and this is after correction. This is after correction. Classical plagiocephaly with a straightforward simple planning, which we call it geometric. This is the same correction, similar planning in a metopic. Again, metopic requires a gentle more of remodeling, because you want to correct the temporal hollowing along with the frontal aspect. So that's after correction on an MDCT. This is after correction. This is after correction. No, gently older child. For the youngsters, this is the classical workhorse of frontorbital advancement and remodeling. This is the frontal flap, and this is the bandeau, which involves, which has a segment which goes into the posterior portion of the bone. These are the frontal flaps for youngers in the crowd. So this is on brachycephaly, the same technique. So all these simple, straightforward single sutures can be tackled through frontorbital advancement and remodeling, and these are close, mostly a aesthetic contribution, plus a gentle ICP issues, of course. So this is now this is a complex craniosynostosis with a in terms of scaphocephaly, where we are demonstrating how we plan using virtual surgical planning, VSP. Again, this is beyond the simple straightforward softwares which are used. Here we are trying to create templates for the correction of scaphocephaly. So as I mentioned, I'm trying to simplify the thought process of creating doing these surgeries. Now, these are templates being placed on the calvarium to create a quick calvarial cuts. So these are the cuts. This is the frontal aspect. These are the parietal aspects. Parietal barrel staving, frontal, posterior aspect. Again, the whole idea is to cut down the surgical time that is required using virtual surgical planning. So this is the post-op. You can see the barrels, radial cuts. The parietal width has increased, and you can see the final effect of it. Some barrel staves, some bone dust being placed backwards. So this is a scaphocephaly. Now this is after surgery. Now this was before. This was before, and you can see the effect after surgery. I mean, we're trying to use present technologies to add or improve our planning. So sometimes we use springs in these some children with metopic. Again, another element of surgical technique. Endoscopy is another technique, which although I'm not going to mention in this talk. Encephalocele and hypertelorism, we consider in the same category, where we require, along with the encephalocele correction, we require correction of hypertelorism and probably the long nose. So this is a child with encephalocele along with hypertelorism in the same instant. So although as a neurosurgical perspective, we look at the encephalocele, the long nose and the hypertelorism needs to be corrected. So this is the classical correction of the encephalocele using the closing the defect with the pericranium, etc., and then a box craniotomy. So this is after surgery. This is him after surgery. Now this is another entity which comes into our same bracket for us, the category 1, where we look at aesthetics. This is an operated child of plagiocephaly. Over time, plagiocephalies have a poor outcome because of some amount of remodeling, some amount of resorption, and some amount of suboptimal response. So this is a 15-year-old child, single suture craniosynostosis, plagiocephaly, And here we are used an overlay technique to correct him. So that's his post correction. So again, straightforward aesthetic issue, and for us the category 1. So this is him after surgery. You can see the correction on the plagiocephalic side. So this is craniofrontonasal dysplasia, a midline cleft on the face along with the calvarium, where again we consider this as a more of a aesthetic response. Apart from, of course, he can have cognitive issues. So this is his MDCT along with his face. Here we use a box craniotomy along with the midline correction. So that's him after surgery. This is craniofrontonasal dysplasia. This is a slightly more complex craniofrontonasal dysplasia with maxilla being involved. So here we do facial bipartition. Now this is clear. This is along with the maxillofacial surgeons, Dr. Pramod, who is my colleague here. So here we do a facial bipartition to improve the maxilla along with the distance between the orbits. So that's post correction. This is post correction, craniofrontal dysplasia. Now, all this come under aesthetics. Again, I'm trying to simplify the perspective involved here. Of course, it's much more complex than however I try to simplify. Category 2 for us is where when you have raised ICP along with aesthetic issues. So this is a complex scaphocephaly, multi-sutural, but dolichocephalic in appearance. So here we'll do a complete cranial vault remodeling. So it has raised ICP along with the aesthetic issues. So this is a corrected version of it. So this is after correction. This is after correction on a longer term follow-up. So next, another situation which comes up in the same scenario where you have ICP and aesthetic issues are situations like this child who had an Appert's, who was 5-year-old. He had severe aesthetic issues because of bone resorption and remodeling, but at the same time he had repeat symptoms of ICP with papilledema. So he's 5-year-old, treated Appert's. So that was his MDCT, and he underwent frontorbital advancement. You can see that his midface is yet to be corrected. So we corrected the frontal advancement, but he did not have much of airway signs, so we are not corrected his airway. So this is the one with ICP in a revision scenario. So the category 3 for us is where airways involved along with aesthetics. So here we have midface distraction along with frontorbital advancement for the aesthetics. So this is a child with proven Cruzen, whose forehead was not much involved, midface was involved. He's had severe airway issues with and an identified Cruzen on genetics. So here we used a monoblock distraction using the internal distractors for the forehead and the midface. So that's him after surgery for his airway and the aesthetic issue. He was genetically proven Cruzen. This is an older child, Cruzen, who was never treated with all signs of Cruzen with performance issues, but primarily she came to us for airway issues at this time. So that's why we put it at category 3, although she has she might have had ICP issues, but at the same time when she presented to us, she was nearly around 12 years old. So here we used a red distractor, where we distracted the forehead and the midface. So that's the maxilla, which was retruded and advanced with the red. So that's her after surgery. So this is a situation where you have ICP, probably some kind of a compensated state, along with airway issues, along with airway issues, and untreated. So in category 4 for us is ICP, airway, and aesthetic issues all involved together. So this is an 11-month-old Cruzen who came to us with full fontanelle. So here, if you see the MDCT, the lambdoid sutures involved, there's an element of Chiari. So this goes for classical posterior calvary wall distraction, like standard technique. Again, and this is one scenario where you can use shunt, but we try to stagger shunt as much as postpone and stagger shunt as much as possible, so that we can allow some physiological correction by using posterior calvary wall distraction. If at all, for the youngsters, if at all we use shunt, we use programmable in these children. if necessary. So this is its this child underwent posterior calvic wall distraction and improved otherwise too. So we sometimes do supraocular, occasionally we do suboccipital, and very rarely we use for foramen decompression to these children. Now this was supraocular, one of the earliest cases which I did. So gently a conservative kind of craniotomy, but otherwise we're more aggressive now. So this is a child after posterior calvic wall distraction. After this, he had frontal involvement and he had mid face involvement with airway issues. So that's his posterior calvarium with improved cystoma magna. So when we have airway issues in these children, we use the ROSA, the robot, to pass the maxillary pin to distract the mid face. So we use a maxillary pin to distract the midface, and this is done under robotic guidance because the midface is very distorted in these children and extremely retruded, putting the molars and the tooth buds and the eye into risk when we pass these transmaxillary pins. So long back they wrote about it. So that's the midface pin to distract the midface. So this is the frontofacial correction. The forehead has been corrected. The midface has been corrected. Here, this issue of ICP along with midface airway issues. So there are scenarios where you have an older child with the same combination of ICP and mid airway issue. Now, in this particular child, this was a 3-year-old with genetic Cruzen. And here the options are either you do stage monoblock or frontofacial. So here we did a monoblock distraction. So for this is the monoblock distraction using internal distractors. So that's internal distractors advancing the forehead and the midface. So this is monoblock distraction. So that's him after correction. You can see the effect on the eyes, the airway improved, and the frontal aspect. So sometimes when we have a delayed presentation, we address only the specific problems because we don't want to disturb the compensated state of the children and the psychological situation. So this was a child who was 17-year-old untreated Cruzen who came to us with this neck pain, suboccipital pain, and the syrinx. Here we treated the foramen decompression alone. That was her presenting complaint at 17 years. But of course, later she asked for aesthetic correction too. So this is a different decision making where you have an untreated situation, and we treat only the condition which presents at the time of presentation. Now this was an appert who had severe performance issues and aesthetic issues. He was 15-year-old. He asked for aesthetic correction, and here we used a red distractor to correct his front length of midface aspect. So this is him after correction. This is an appert which was again treated in a delayed manner. You can see the amount of effect he could get. But again, you should remember that the performance is not changed because he's damaged since long. Now, so essentially, because of all these issues, we are gently aggressive in decision making, which we refer to as a 360-degree approach to syndromic facial craniosynostosis. The hypothesis being early ICP correction is a key for functional outcome. Timing of FOIR is important because it gives a very good functional aesthetic outcome and probably what we refer to as global decompression. Significant airway issues are important for cognitive development, which again, all neurosurgeons amongst us should be reminded of. Sleep quality is equally an important phenomenon that improves performance and contributes to functional outcome in these children. So early addressal of midface is important for a good psychological outcome. So that's why we are a bit on the aggressive side to address all these issues as early as possible, one after another. So this is our protocol for facial craniosynostosis. When we when they come youngest to us, when they have Chiari, etc., we do a posterior calvic wall distraction, and then during the distractor removal, we do the frontofacial or the monoblock using the robot. So, and or we might do a midface distraction and then do a stage it to do a frontorbital advancement. This is so each of the distractor removal is 3 to the distract removal, we add another secondary procedure for the face or the mid face in these children. If it's an older child, we would either do the face and the forehead only without getting the PCVD into place for older children beyond 2 years, and keeping PCVD as a adjunct for later usage only. So this is our protocol for now for the youngest ones who come to us with facial craniosynostosis. Just to give you an example, this is a child. This is a situation where we do a PCVD, mid face, and frontorbital advancement all together, one after another during the distract removal. So this is an example of a child who came to us with a shunt where we did a shunt from outside, Cruzen. So we did a PCVD, a posterior calvé wall distraction, and then went on to do a mid face and the forehead, and then FOIR, frontorbital advancement. So we have covered the calvarium completely in all ways, according to our philosophy. Sometimes we do the posterior calvé wall distraction and the mid face alone. In children who do not require frontorbital advancement. Now, this child had some element of hydrocephalus, probably such as the frontal bossing was there. So we did a posterior calvé wall distraction and the mid face. So that's her. Now she's about 9 years now. Recently, she came to us with again airway issues. So she's waiting for a revision airway mid-face correction. So, and although an early mid-face correction is very probably is very rewarding for these children who have airway issues and to improve their aesthetics, but they usually require a mid-face correction later in life because of lack of growth of the face as they grow over age. So sometimes we do frontorbital advancement and mid-face alone. Now this is usually in older children. Now this was a 2-year-old who presented to us with this plagiocephalic-like appearance, but genetically proven Cruzen. So here she went FOIR initially, but had severe airway, then went on to have a mid-face distraction. So here she did not have an PCVD. As I mentioned, for older children, we try to avoid PCVD, keeping PCVD as a later option in these children. Sometimes the child which I mentioned earlier, again, a PCVD with frontofacial. So this is another set of combination of surgeries with a comprehensive approach. So this is the same child from here to here onwards. Multiple surgeries, one after other. So we consider 5 years as upper limit because probably the brain growth is maximum by around 5 years, 100%, and to improve the cognitive development and to avoid damage to the self-image. So we try to move the surgical strategy fast in these children. So essentially, age and presentation are key to outcome and decision making to avoid secondary goals. And so functional performance altogether, including the cognition, psychology, etc., should remain the yardstick for analyzing treatment outcomes. So at the same time, just to mention that although I am speaking, I'm speaking in for all of the members who take part in improvement of these kids, and most importantly, it's the parent that that helps us. Especially a motivated parent can change the outcome of such children who are extremely damaged if not treated timely or if not treated appropriately. Essentially, if you look at the whole journey of these kids, is a journey of survival of the child, the family, and the world, and it demonstrates that we all care for these kids. Thank you.
Thank you very much, sir. Thank you very much, Professor Suhas. It was really an enlightening talk, and in a very crisp manner, we have gone through all the major types of the complex craniosynostosis, and they are equally complex but enthusiastic and fascinating surgical management of these patients. So there are a lot of questions for you from the audience, and definitely from younger generation at our place also. And with this, we will take all the questions at the end of the second talk. And with this, I would like to invite Dr. Subhash Konar, sir, from NIMHANS, Bangalore. May we have your slide, sir?
Yeah, I am audible?
Yes, sir, you are audible.
Yeah.
Yes. So
Screen is visible?
yes, sir, it is visible there. And you can, okay. So let's go with the second part of the talk, and then we will take the questions together. Thank you very much.
Yeah. Good afternoon, everybody. To start with, thank you, Jitendra, for inviting me for this talk, and to my respected teacher. I'm going to cover the craniosynostosis and the ICP management part. So what is the prevalence of raised ICP assessed preoperatively? So it was like more, the incidence of raised ICP is more in sagittal synostosis, followed by unicoronal or metopic. And obviously in syndromic, the raised ICP features are more compared to non-syndromic. And among the in syndromic, like Cruzen and apart has more prevalence of raised ICP. So about pathophysiology, the raised ICP is like a closed circuit like craniosynostosis, like if there is a posterior cranial vault, small volume, so narrow posterior fossa will cause fourth ventricular outlet obstruction, will cause the hydrocephalus, it will increase the raised ICP, or maybe the obstructive sleep apnea also contribute, and sometimes increased venous pressure also contribute to hydrocephalus and raised ICP. When there is a raised ICP, it will cause tonsillar herniation, causing fourth ventricular obstruction, hydrocephalus, and raised ICP. So what are the main causes? Like there are the three main cause of increased ICP in craniosynostosis, like because of restriction of the normal expansion of the skull to accommodate growing brain leading to raised ICP, or there is a impaired or problem in circulation or absorption of the CSF, potentially leading to hydrocephalus, or there will be a venous obstruction causing raised ICP. Why you need to and when to monitor ICP? So it will help in understanding the severity of the increased pressure, and it also helps the timing of the surgery, evaluate the effectiveness of the surgical procedure, need to normalize the ICP and therefore reduce the risk of long-term sequelae of ICP elevation, and intra-op ICP monitoring. Intra-op ICP monitoring is very important. It will help in guiding the correction of the overall shape, the cranial, like in case of total cranial vault expansion, like what Suhas sir was showing in case of syndromic, we need to correct so many things, and it will also help when you are doing a height reduction for the correction of the abnormal to raise shape from the skull. In case of bicoronal synostosis, intra-op ICP monitoring is very helpful. What are the types of ICP monitoring? Like we can use interparenchymal, epidural, interventricular, or subarachnoid. It's like same as like we do in a TBI cases. So now I'm going in detail, like there's a nice paper published, intracranial pressure in a single suture craniosynostosis, and they have done for 74 cases. In that, unilateral coronal cases are more, and they have found like 17% cases of overall 74, there is an increased ICP, and borderline like in 38% cases. If you see here, like the age is the factor. If the patient present with like older age, the chances of increased ICP is more compared to the younger children. And if you'll see here in this here that coronal the sagittal craniosynostosis has more chances of raised ICP compared to metopic or coronal. So I see craniosynostosis, like the incidence is more. So I took this paper to describe more. Like this is a nice paper published in 2014 by the Oxford group. What they have found that the sagittal craniosynostosis they have divided into marked and mild and no scaphocephaly. What important thing is that even the mild scaphocephaly patients, there is a raised almost like a 64% more raised ICP compared to the mark scaphocephaly, and even in a non-scaphocephaly patient also. So what are the factors, like how the age is related, how the sutures involvement related, how the syndromes are related with elevated intracranial pressure? This is a nice paper. They have analyzed the older age, like age is one of the contributing factor, and if every month like the child is growing, so it will contribute to 0.06 millimeter of ICP, and it is in the regression analysis also it is significant. Even the multiple suture involvement also contribute. It is like it will contribute, one suture involvement will contribute almost like 4 millimeter more ICP. Even the syndromic presence of syndromic craniosynostosis will contribute to 3 millimeter more ICP, and it is also statistically significant. And the same paper, what they have found, like what is the ICP values, like what is the intracranial pressure? What they found in case of sagittal, it will be around 16 millimeter, and in unicoronal is 14, in metopic is 12, and they compare single versus multiple. In a multiple suture involvement, like almost 18, and in single it is. So this is also one more interesting paper. It's just published in May 2024 in neurosurgery. What they have done in a craniosynostosis patients, how the perfusion parameter or PRX, like the cerebral autoregulation related with ICP in case of craniosynostosis patient. What they have found before the decompression, the cerebral blood flow was like 257, and definitely after surgery, it was improved. Even the cerebral velocity also improved, and the PRX also they have found, like if ICP in the top before decompression, if it's less than 12 millimeter, it is 0.37. If the ICP is more than 12, it is 0.26. That means that if ICP is more than 12, definitely the cerebral autoregulation is impaired. Even before decompression, in case of like coronal or metopic versus sagittal, you can see they're nicely divided. ICP less than 10 millimeter, ICP in the borderline, like less than 10 is normal, borderline 10 to 15, ICP more than 15. What they found after decompression, definitely there is an advantage of surgery. That all this, you can see the orange pillar, all are reduced after surgery. Even the normal range also improve. So definitely there is a role of surgery for ICP management, and the timing also important, as well as the age. So that is about single suture involvement, and obviously in case of syndromic apart or Cruzen, there is a high chance of raised ICP. These are the few paper. They have found 83% patients with apart with raised ICP and 61% in Cruzen. It's a very interesting paper that is published in Developmental Medicine and Child Neurology. This paper, what in a craniosynostosis children, what they have seen, the intracranial pressure and effect of the intracranial pressure on the cortical thickness in case of syndromic craniosynostosis. They have included 107 children, 171 MRI scans done. What they have found, the mean cortical thickness in syndromic craniosynostosis is 2.78 millimeter. And the factor which are related with cortical thinning is the presence of papilledema and hydrocephalus. So both are the factor. It is directly related and significant in cortical thinning. And there are factors not related with thinnings are gender, syndromic presence, OSA, and head circumference and tonsillar position. How will screen for raised ICP? Clinical symptom, obviously, like there will be a deflection of the head circumference growth curve. Most important is fundoscopy. Fundoscopy, we have to look for a papilledema. These are the few papers published related with in craniosynostosis related with raised ICP and papilledema. The sensitivity of detecting papilledema and raised ICP is almost like it's range from 17 to 22%. The Tutti et al. They have found very nice findings, like age is less than 8 years, the sensitivity range is 22%, and if age is more than 8 years, it is 100%. So definitely the age is a factor. So if the younger age, the getting the papilledema and correlation is not that good as the older children. Specificity, obviously, it range from 98 to 100%. So now on the clinical, I'm going to a little bit of radiology, like what are the correlation of radiological appearance with ICP. This is a paper published in Neurosurgery in 1996 about the copper bitten appearance. We know that raised ICP will cause copper bitten appearance, and in a craniosynostosis, we see regularly this appearance. So in this study, they have seen the X-ray correlation and the CT correlation, and the findings with the ICP range, that how it is related. What they have found when you are doing just simple cranial X-ray, the dorsal, if the dorsum sella erosion is present, that means the ICP is high and its range is almost like 15 to 20 millimeter. And even the wall suture score is more than 4, the value is 14.8 plus minus 5.4. In the CT scan, how they are correlated, what are the findings of CT findings and CT findings and the ICP? It is like if there is a presence of hydrocephalus, obviously ICP is high. And if there is an obliteration of anterior sulci and posterior sulci, the ICP is 14.4 into 14.6. So these are other radiological findings. This is the paper. It was published in AJNR. The jugular foramina complex in syndromic cases. And what they have found, the jugular foramina diameter in cases of syndromic children is 6.5 and a non-syndromic is 11.5. And it is significantly related with raised ICP. So how we'll investigate the raised ICP, like after the clinical and radiology, one is optic nerve sheath diameter, one is OCT, one is VEP, other is invasive ICP monitoring. So ONSD, it is the bedside, like we can do simply with ultrasound. And how ONSD is related. This paper in child nervous system, they have found if age is less than 1 year, the craniosynostosis patient with raised ICP, the ONSD values are 5. And if it is more than 1 year, it is definitely high, 6.36, compared to without evidence of clinical or radiological evidence of ICP, the values is 4 versus 5.34, and in control is obviously less. Even the OCT, the cutoff for OCT of elevated raised ICP is when there's a maximal retinal nerve fiber thickness layer exceed 207 micrometer, or the maximal anterior retinal projection exceed 159 micrometer. And this is the cutoff value in OCT to detect raised ICP in case of craniosynostosis. And this cutoff value has the sensitivity of 89% and specificity of 62%. And they have found, like in case of multisutural and syndromic, it is obviously high and it is nicely correlating. Even the age factor, when the child present with in the older age, the raised ICP features are high, and even the OCT values are also high. Even the visual evoked potential also we can see. And if you are doing a serial VEP in patient of craniosynostosis with is correlating with invasive. So what this paper they have found, the latency is high in case of raised ICP. However, the amplitude is low in case of raised ICP. So now invasive ICP, why we do not monitor invasive ICP, why it is not like a gold standard? Because it is not universally accepted scale, or the values are still not standardized in a pediatric case. Like normal range, we see less than 10 millimeter, borderline 10 to 15, abnormal is above 15. There are limited number of paper pre-op, post-op comparison, and it's difficult to admit a children in ICU for pre-op monitoring. There is a risk of ICP monitoring. So now telemetry monitoring also has come, but it is not universally available. So what do you mean by telemetric intracranial pressure monitoring? We can do for a persistent, like even after surgery, we can monitor persistent or recurrent intracranial hypertension after surgery. And you can do a cutoff value or a continuous value. You can see a parenchymal probe here. We have to put inside the brain parenchyma, and this is the transducer. This transducer you have to place between the calvary and galea. And after placement, we can do in a post-op with this probe over the transducer, and we can monitor either one-time ICP or continuous. This is the advantage that in a children, like we can monitor in post-op this telemetric ICP monitoring. So we can do overnight ICP monitoring. This paper also they quoted that it has an advantage, like in cases of suspected craniosynostosis, where you have a doubt that ICP is really high or not. And we can, this paper, they correlated with the MRI findings. What they have found that if there is a obliteration of the CSF space in MRI, definitely the ICP is high. Even the amplitude, like mean RAP, it is the ratio of amplitude of the ICP. Like if you take for 10 second 30 ICP monitoring, So what are the correlation ratio will come? That is means this RAP, and RAP is significantly lower, and it is nicely correlated with the MRI findings. Like RAP will increase in more where there is a more copper beaten appearance. Intra ICP monitoring, we have published an article from Nimans, like we have done invasive ICP parenchymal or interventricular ICP monitoring. We have included 28 patients. This is like a pilot study. What we have found, like opening ICP pressure was 23, the range was 7 to 40, and more than 15 ICP, like high ICP, we found almost like 64.3% cases. Mean ICP where required shunt is 24, and mean ICP where the cranial wall modeling done in 22.7%. So in our study, we found 28.6% patient presented with papilledema, and there is a prominent vein on scapula, 10.7% cases, copper beaten appearance in 64.3% cases. So we can see here like ICP monitoring intra-op, this is interventricular one, where the ICP was 9. And when we are trying to do height reduction and remodeling, then we found slightly high, and then we modify accordingly and depending on the ICP values. So in this case, we have found like ICP is very high, like almost like 40. Even in the waveform also, you can see the P2, like P1, P2, P3, the P2 is higher than P1. So definitely there is a raised ICP with less compliance, less brain compliance. This is a case of a Craniosynostosis where you use the ICP intra-op ICP monitor, and accordingly we modified our surgery and we did anticranial wall expansion. So this is our like plotted graph where opening ICP is high. After surgery, it was low, and when we tried to do height reduction, slightly increase, and then we adjusted at the time of closure. Even the same thing, the mean value we have plotted, and we found like curve like this. So what we did in our study, like if the ICP range is 15 to 20, in 2 cases it was normal, and 2 cases required additional CSF diversion because it was high. And if it is value is more than 20 millimeter, there is we didn't do the height reduction. So about treatment. So this is like a flow chart of managing. It is like same, even sir also presented, like if there is a raised ICP feature, if it is yes, then if it is a multisutural involvement and craniosynostosis or syndromic, we have to do combination of anterocranial expansion with anterior advancement. And if it is or whatever the type of craniosynostosis, we have to do the surgery. So the treatment of raised ICP, what I want to focus is focus on the underlying cause. Like if it is a sagittal synostosis, if it is a small intercranial volume, you should go for a cranial expansion surgery. In case of a syndromic craniosynostosis, a combination of factor in play. Like if it is a small intercranial, definitely surgery is venous hypertension or hydrocephalus or OSA. We may have to address the hydrocephalus if it is persistent ICP is there, or OSA with like mid-phase advancement like sir has shown. So if you'll go for all the surgery, maybe those factors can be taken care. It's a very interesting paper. It was published like even the raised ICP will be there after the correction. And what is the incidence? The incidence, it's a systemic review. And they have found the overall the range is 1.5 to 11%, and the pool data is 5%. So even after doing the surgery, ICP may be high. So, and in non-syndromic cases, the pool data shows like 4%, and obviously it is high in syndromic cases, like 6 to 38% patients can have a raised ICP. So you have to address this according to the problem. Like if it is high, if there is a hydrocephalus, you have to go for a CSF diversion. And these patients need a close follow-up. So my conclusion is that utility of ICP monitoring during surgery for guiding the extent of surgery, type of surgery, and the need of further surgical procedure. It help in intra-op ICP monitoring. It will help a modification of surgical procedure. Even perioperative ICP monitoring also help to define the indication of VP shunt. Like in our case, 2 patients required additional CSF diversion even after cranial vault modeling. Thank you.
Thank you very much, sir. Thank you so much for enlightening us again on the matter of ICP, role of ICP monitoring during the surgery, intraoperatively or postoperatively. So I would like to hand over the virtual mic to the panelist, senior panelist, Professor Ajay Sinha sir from Liverpool, UK, and Professor A.K. Mahapatra sir.
Can I comment? Can I comment? Can I comment?
Yes, sir, please, definitely.
Yes,
See, I think we all underestimate the intracranial hypertension. If you do the cerebral perfusion studies, you don't have to go up to 15 mm, 15 millimeter mercury. About 20 years back or so, Deepak Agarwal and myself did the intracranial pressure monitoring in a normal Craniosynostoses. That is because in relation to a paper by Dr. Wang from Seoul, he said about 50% people of Craniosynostoses were doing hypertension. So we had done 13 there. Here I have done few cases. When I do the pre and post of PET CT or SPECT CT, the cerebral perfusion is very low in bifrontal area. Sometimes there will be diffuse hyperperfusion in the entire. The child is so small, maybe less than 2 years or so. So he cannot wait up to 15 millimeter mercury to be very high, because in small children with a growing brain, 15 millimeter will be very high pressure, which can damage the brain. I think. Second thing, we do not many papers are published in the cerebral perfusion studies.
yes, sir.
Hiroko, and not people talk about psychometric analysis. We only talk cosmetic. What happens to their brain function, IQ, performance only, and some papers are published from other places that whatever you do, their performance is not that good if you go up to follow them for 10 to 15 years. So I think one is cosmetic surgery, one is intracranial pressure monitoring, but ultimate goal that their functional outcome is very hardly published and also recognized. Thank you.
Thank you very much, sir, for your special comment. And Professor Ajay, sir.
I mean, first and foremost, thank you both for wonderful presentation. It was fantastic
Absolutely
presentation.
fantastic.
Really learned a lot from both of you. I mean, two things. Obviously, raised pressure is very important. In syndromic, the most important person who looks after the child in the first few days of life is the ENT surgeon and the ophthalmologist, because establishing proper breathing is ABC. Airway comes first.
Yes.
So, you've got to have proper airways. And maybe looking at the spectrum of, healthcare across the country, perhaps Suhas is a bit more fortunate that way, that he gets some of this patient early on. Because in most other places where children are born in remote part of the country, even to establish good airway early on in life is not going to be an easy affair. And so I suspect some of these children who have severe OSA or CSA, cerebral, central or obstructive sleep apneas, may not even make it to tertiary centers. The airway is the most important, and what we have achieved over the last 20 years, or 25 years, which I have been working on this, our incidence of tracheostomy has come down with aggressive use of nasopharyngeal airways in early on. That's something which we have mastered over the years, so the using of nasopharyngeal airways, and it's a bit labor intensive. You have to train the nurses, you have to train the parents. If the parents don't have a high education standard or they're not engaged, it becomes very difficult to get them to do it, to change it regularly. But with effective use of nasopharyngeal airways, we have been able to establish, avoid or reduce the incidence of tracheostomy. But nevertheless, despite all effort, there will be a small subset of patients who will require tracheostomy early on. You cannot avoid it. Otherwise, you lose the child. And the second one is you have to establish feeding early on, because they cannot breathe well. They don't suck mother's milk. They can't put on weight. And if you are operating on an underweight child, you're likely to have a lot of complications. So some of these cases, you may have to even do an early gastrostomy to establish feeding well. And then only you can move on to the next stage. And Suhas very nicely showed the various stages of management of, using mid-phase distractors, which is something which they have in the world They're the world authority on it. No two doubts about it. They are the ones who have been dealing with it early on. But nevertheless, it's from what I can make out, when you follow up this patient, and Suhas alluded to it in his talk, some of these patients who are going for early mid-phase distraction using pins will also require a second stage mid-phase advancement at a later date, which will be around 10, 12, 13 years of age, because the mid-phase continues to grow and you are operating on a moving goalpost. So by the time the mid-phase growth is complete, which is between 12 to 14 years of age, I suspect some of these children who have been distracted using mid-phase pins will once again regress back, and it will require second stage mid-phase advancement at a later date. It may not be a LIFO 3 osteotomy, maybe LIFO 2, but that's something which you have to keep in mind. And with regards to Suhas's paper, fantastic paper, he has really done a thorough literature search. I mean, in terms of our experience with raised pressure in non-syndromics, sagittal outstrips every other condition. The incidence was standard quote is about 10 to 15%. I suspect is a bit higher. I mean, the Oxford paper quotes are much higher, but they tend to use a slightly different parameters for assessing ICP. In our practice, I suspect it's about 12 to 14%. Isolated metopics, I have not seen a huge amount. I think in our experience, we don't do preoperative ICP monitoring, so it's difficult for me to give you an answer on that. But some of these patients who present later on in life with just simple headaches, or parents are concerned about their behavioral changes, and we have had to operate on a few patients, or by putting an ICP probe, we have not picked up a huge amount of raised pressure. I don't remember even one. And we have one of the largest series in the world. I think 350 cases we wrote up recently in of isolated metafic synostosis. So that's something which I just wanted to add to the discussion.
Hey, Ajay, can I just tell me, do you do routine IC monitoring?
No.
Or are you do perfusion?
We are not doing perfusion routinely.
Unless you do it, in a small child will not know the mild intracranial hypertension. If
I agree.
If it is 7 or 10 in a child of 6 months or 1 year, that's good enough to damage brain.
Yes, sir.
10 is good enough.
Yeah, I agree. We don't do pre-op, and what is a normal in a 1-year-old child? There is no data.
6 or 7. 6 or 7. No. There is one paper, Derek Bruce. 6 to 7 we can take as normal.
Yeah, that's why I said there is such an old paper, and it's a single center study. Nobody knows what is the normal pressure of a 1-month-old child, or a 6-month-old child, or a 1-year-old child.
We should do it.
Yeah. I mean, this is such an ethical thing, isn't it? Who will subject their normal child to ICP monitoring? Unless until we have a very non-invasive way, this study will never take off. So we have to wait till we have a confirmed non-invasive way of monitoring pressure.
No, sorry. You do a perfusion studies.
Perfusion.
That's
not a surrogate for.
See, I have done 7 or 8 cases in this hospital. You will not able to understand the huge perfusion report given by the specialist. They will never complain of breast pressure. No, nothing, no changes.
Agree. I know. Perfusion, they solved. I mean, Dirocco did a study long back on sagittal stenosis, where he found that the paraxial cortical matter, perfusion improved after simple strip craniectomy. So the perfusion studies have been done. We did a very basic pilot study looking at pressure before and after vault remodeling in scaphocephaly, and we did find that if you're doing if you're trying to do any squeeze, the pressure just shoots up very, very dramatically, and you can see it on the table. But then also we had to do it only with a subdural, with a extradural probe. We couldn't do a subdural because of ethical issues. I'll stop there.
Thank you very much, sir. Professor Raja, you're muted, I guess.
Wait, can I leave? I have another program. Or anybody want to ask? Can I leave?
Yes, sure, please, sir, please.
Dr. Jitendra,
thanks to everyone. Always a pleasure talking to you.
Thank you, Dr.
Yes, sir.
Thank you very much for coming.
I have to leave for another program.
Thank you, Dr.
No problem.
Bye.
sir. Thank
Thank
you
you.
so much.
Thank you.
Thank you,
Thank you,
sir.
sir. Thank you for joining, sir.
May I invite Professor Mittal sir for your special comment, sir? Or
Oh, thank you very much. I had some problem with my net, so I was disconnected in between. So I could not.
no problem, sir.
But I think it is a. I will give thanks to Jitendra for organizing these all things.
Oh,
Thank you, Jitendra.
Thank you, sir. Professor Suhas, you have a question. There are multiple questions for you. So I'll go one by one. Dr. Jitin, are you still there? And because your question is, what are the contraindications of craniosynostosis surgery or clinical features when the surgical results are very poor? So, Dr. Jitin, if you are here in the panel, can you just elaborate your question regarding what do you want to ask regarding the contraindication when the clinical features in the post-op are the aesthetic result or the functional outcome?
Thank you. Thank you. I was just asking what are the preoperative indications when their results are very poor and we should not go ahead with the surgery.
I think at the outset, I would say there is no situation where I would not go ahead for surgery, because this is a very human issue, and there's basic survival depends on that we perform something for them appropriately.
Absolutely.
Yeah, I mean, it's a highly ethical issue. Any pediatric condition, unless of course oncological conditions, which let's say a high-end kind of a very oncologically dismal tumor like brainstem tumor, I would not desist from treatment anytime. Zero. No confusion there. And again, but the crux of it is, it's not the neurosurgeon alone who is involved. There has to be a team or appropriately trained people to get involved, because each of these surgeries are very treacherous. So anybody who handles this patient, it cannot be or should ever be a one-time affair. You have learned from textbooks, but handling these children on table is a very demanding effort. So textbooks is okay, talks are okay, but treating these surgeries are highly responsible jobs. So essentially, decide and execute as safely as possible. No confusion there.
For beginners, the only thing I would suggest is don't start with syndromics. You'll burn your fingers very badly. Start with simple scaphocephalies at a push metopic, and then move on to the more serious ones.
Yeah.
Yes, sir. There is one more question for both the either of the speaker can take up this. What complications for the distractor, for the posterior vault distraction surgeries? What complications have you most commonly encountered with? This is a question from Dr. Kunal, our resident, one of our resident at AIMS Rishikesh.
What sir can address, sir? Because you have more experience than us.
Yeah, I know, but maybe I'll ask Dr. Sinha because he's my senior. So, Dr. Sinha, you want to start, and then I can.
Sorry, I got a bit distracted about the complications.
I mean, posterior vault.
Distractor.
Posterior vault.
Posterior vault
distractor. I mean, everything from simple, causing damage to the brain, CSF leaks, infection. I mean, the commonest problem we notice is not knowing how to position it properly. In the talk I gave in Shillong, I talked about positioning the patient on the table. You can do a wonderful surgery, and if you don't protect the eyes properly, because they hardly have any supraorbital eyebrows. There is no eyebrows for them. So the both globes are not well protected, and if you don't pad the face well, if you don't protect the eyes well, you'll do a very wonderful surgery, and the patient will wake up blind with severe ocular damage. So we start from there, right from the beginning. Positioning of the patient, to proper padding of the face, to make sure that you don't damage the dura when you're doing the craniotomy. Because if you get a CSF leak, the risk of infection just increases exponentially, because you have a exposure to the environment, because the distractors are coming through the skin, so bugs can go in. So you have to have try and minimize or avoid CSF leaks at every cost, and you make sure that in the pins, the screws don't go through the dura. So you have to protect that as well. And in the post-op, the biggest thing we notice, if even everything goes well, there's a lot of leakage of blood from the pin sites. And so you have to put extra stitches just to stop leakage of blood, because children, even that amount of blood loss can lead to, severe drop in hemoglobin and need for transfusion. And then afterwards, it's because the bone is so thin, and if you don't choose your cases well, if you don't get a good purchase on the bone, the distractor plate will work its way through the skin. It will come off. You not get a good purchase on the bone, then you're in for trouble. So these are the things you have to keep in mind. Then you have to be watching it. You have to almost have a weekly review of these cases, because if you're distracting one side, other side you have to distract a bit less. So because some of the children also have an element of plagiocephaly. So you have to keep it in. So your weekly review is a must, and weekly wound check, and make sure that you are happy with the distraction. And with regular X-rays, you don't have to do a CT, but regular X-rays, to just ensure that the distraction is actually happening, because you might be turning the pins, and actually the distraction may not be happening. In one particular case, the parents were not distracting at all. They were just as much as you teach them, they would not stop before they click. You're supposed to turn two anti-clockwise turns. So they were doing two. They thought they were doing two, but actually they were not even doing that much. So ultimately we had to go in again because of the distraction didn't work. So these are all things which you have to keep in mind when you're dealing with this. It's a very labor-intensive procedure. You need very good nursing backup.
Yes, but wonderful answers, sir. To the point and very precise, very surgically, very practical answer. Thank you very much. And then I would like to invite Professor Altaf Ramzan for his comments on these complex craniosynostosis and ICP monitoring. Professor Altaf, sir, are you here? Can you hear me? I think there's no response. So I'll just move on to the one more, and in the sake of time, one last question from one of the resident again. What is the fundamental difference do we as a surgeon follow while treating craniosynostosis in adolescent versus child? What should be the basic fundamental difference in the philosophy of operating these adolescents?
Can I try?
Yes, sir, please.
Yeah, so adolescents are a completely different strategy. Of course, we need to look at what is troubling them at that particular moment. Mostly it's aesthetics, but because the performance is usually damaged if they have never been treated, especially if the child has ICP. As I mentioned, a child with Cruzen who has never been treated, the performances, or a PERTS who has never been treated, is usually the performance is extremely damaged. So the next question comes up is, if you want to handle aesthetics, what are you going to deliver? The most important aspect we need to understand is, even if you deliver an optimal aesthetics, they are psychologically damaged in many forms. So being realistic in terms of expectations is very important in these older children. So you have an aesthetically optimal outcome according to you, but they might not feel the same because they're psychologically affected already because of the poor self-image secondary to the damage which has been long-standing. This is the second issue. The third important issue is they are in a very extremely compensated form of ICP. So any kind of surgery can be treacherous in these children because they have emissaries, etc., very well built into the system, so that anytime you do a surgery on the calvarium, the surgery can itself be very damaging in terms of dura, brain, emissaries, blood loss, and damage to the great veins. So essentially, deciding on adolescent or older children or older patient is a very fine line of strategy. So all this should be discussed well in advance with the parents and the guardians and the child if necessary. I think that would be my take on it.
I mean, just to add to what Suhas said, I mean, I fully agree with what you said. Yeah, the goalpost shifts in adolescence. We are looking more towards aesthetics rather than functional outcomes.
Yes.
Very rarely do you have cases where there is actually a functional element to surgery, patient with severe raised pressure. We do get a small percentage of cases, where you have totally untreated cruisons, totally untreated, APERS. 5% don't make it to adolescence without treatment, they die. But you do get a small percentage of cruisons or APERS or, simple scephalopathies who have not been treated and come into adolescent life and present with raised pressure. We do come across that. So there you have to evaluate whether you're looking at from a surgical perspective, whether it's simply aesthetics or it is functional. And if it is simply aesthetics, then you have to try to do the bare minimum. And when it comes to aesthetics, then this is the place where you need modeling, you need 3D models, you need operating on your simulators, on either you have computer simulators or 3D model surgery. That's where this becomes very vital to actually work it out what you want to get, whether you want to get a good nasofrontal angle or you want to get a good position in the forehead, or you want to get a lowered eyebrows or lowered hairline. Everything is important, and you will find that most of the things you have to fall back on a good plastic maxillofacial surgeon. Because neurosurgeons, we may claim we know everything, but our aesthetic attitude is very poor. We are not trained to look into the aesthetics, and let's be honest about it. We are more doing, when it comes to functional, perhaps we do a better job. When it comes to aesthetic, you have to fall back on people who know what they're doing, who know whose training is towards the aesthetics. I mean, we are not trained. That's all it's fact.
Definitely, sir.
Absolutely agree.
Absolutely
To save
true.
lives.
We respect brain a lot, but now we have Professor Dhaval with us, and I would like to invite Professor Dhaval for giving his final concluding comment on this fascinating, interesting pathology and treatment. Dhaval, sir. I think
sir, it's just login.
is maybe, yeah. So with this, we come to the end of this webinar. And if there are no further questions, Professor Dhaval, if you can listen to me, may I invite you for the final concluding comment on the topic?
I just not logged in. I finished one emergency surgery. I could not.
I was expecting the same answer, but still you have to give some comment for us.
You have not heard anything. I cannot give any comment.
No, not on. No, it's okay, but it's okay. No problem. On your behalf, Dr. Subhash has already given so very well and to the point presentation on that topic. So with this, I would like to conclude the webinar and thanks our speakers whom I have kept, and on the behalf of NSSI, I would like to thank Professor Suhas, Dr. Subhash, Professor Ajay, Professor A.K. Mahapatra, sir, and Professor Mittal, Professor Altaf, everyone who I have kept away from the family for this webinar, for this fascinating topic. It is really interesting, and I learned a lot. I believe that every one of us has got enlightened on this this interesting topic. Thank you very much, sir. Thank you.
Thank you so
Thank
much.
you. Thank you. Thank you.
Thank you. Thank you.
Thank you,
sir.
Thank you, everybody. Good night.
Good night, sir. Bye.
Good